Nephrotic patients typically first seek medical help for edema, while a nephritic patient's chief complaint usually includes bloody urine and reduced urine output, with a relatively milder degree of edema. Subsequent examination and testing will reveal massive proteinuria, fatty casts in urine, low serum albumin, and high blood lipids in nephrotic syndrome, while nephritic patients will have red blood cells in urine, often with casts, mild proteinuria, elevated serum creatinine, and high blood pressure. Both syndromes result from damage to the glomeruli in the kidney. A glomerulus is basically a ball of capillaries where the filtration of blood into urine takes place. In a healthy kidney, the glomerular filtration membrane allows only small molecules to pass through. This membrane has three components: the fenestrated endothelium of blood capillaries, the glomerular basement membrane, and the glomerular epithelium made of podocytes. In nephrotic syndrome, changes in the membrane's permeability allow proteins to pass into urine. The underlying damage is usually non-inflammatory, and in most cases mainly affects podocytes. Nephritic syndrome, on the other hand, is characterized by an overwhelming inflammation that results in massive infiltration of immune cells, deposition of immune complexes, and abnormal proliferation of glomerular cells. These buildups block filtration, reducing urine output, and cause the capillaries to rupture, releasing red blood cells into urine. The coagulation cascade may also be activated locally, producing tiny blood clots, further obstructing filtration. Common microscopic findings include effacement of podocyte foot processes in nephrotic syndrome and immune deposits with or without proliferation in nephritic glomeruli. The two syndromes have different sets of causes, although some disorders such as lupus can cause both conditions. Autoimmune response underlies both groups of diseases, but infections have a significant share in etiology of nephritic syndrome, responsible for its acute presentation. Nephrotic forms, on the other hand, are mainly chronic. Both syndromes can also coexist in some conditions. Treatment for autoimmune causes in both groups typically includes immunosuppressive therapy and symptom management. An important difference must be noted for treatment of infection-associated glomerulonephritis, for which the use of immunosuppressants is controversial, and appropriate antibiotics are used instead. Acute glomerulonephritis can quickly compromise renal function, and hence requires rapid intervention and close monitoring. Depending on the cause, it may resolve quickly or progress to chronic kidney disease. Nephrotic syndrome, except for minimal change disease, often remains chronic with long-term risks for cardiovascular events due to high blood lipids and hypercoagulability. Minimal change disease typically responds well to corticosteroid treatment, but relapses are common.
Are you a fan of Alila Medical videos? If so, you will love our new Alila Academy. Based entirely on our highly effective animated mini lectures, our courses are designed to follow a typical syllabus in each subject. Each topic is extensively illustrated and comes with quizzes to test your understanding, downloadable PDFs for a quick review, as well as images for you to use in school projects or presentations. We are known for producing highly effective animated videos that explain the most difficult concepts in record time. We have no doubt that our courses will be a lifesaver for both students and teachers alike, so do come check them out. Alila Academy. Clear, concise, effective, with extensive visual resource. No one explains like Alila does.